So there are cases, you know, the rates of surgical complications. There are cases in which you wish why the patient came to me. There are cases in which you wish why you chose to operate it. There are cases in which you wish why did you even take up surgery. So this is one of the cases. So this is not the deteriorating cascade was fortunately not started by me. This was a 67-year-old male, senior physician, diabetic, hypertensive, morbidly obese. So he was 120 kgs and a short guy as well. So he had an L4-5 canal stenosis and claudication, and he had gone elsewhere, and what was done was an L3 to 5, an open decompressive laminectomy and fusion. He had improved transiently after the surgery, but unfortunately he developed a post-operative, very severe, an entire length of the incision. It was a pretty large incision because he was very obese, to do an open surgery. The incision was large, and he developed a post-operative wound dehiscence. It completely opened up apparently, which we don't have the detailed records of. And he was readmitted, debridement was done, and secondary suturing was done. And after that, he was doing okay. After a few months, he came to us with severe low back pain radiating to anterior aspect of the thigh. He was unable to stand or walk even for 5 minutes. Progressive. It was since the last 2 months. He came actually in a wheelchair, and there were no gross motor or sensory deficits. And when we got a standing X-ray done, flexion, extension, dynamic, this was the picture. So there's already a fusion level, an L4-5 cage is there, which is pretty good. An L3-4, there was no record in the mention. We don't have his preoperative images or the first images, immediate post-operative images, unfortunately. But the records mentioned that an L3-4, there was only mild lateral recess stenosis, but the L3 was included in the fusion level. And as we can see, there is a mild retrolisthesis there, which doesn't seem to be very unstable. There's a vacuum in the disc as well. But the main problem seems to be at L2-3, where you can see there is a significant anterior disc collapse, and which is completely opening up on an extension view. So this is the MRI, which again shows the anterior inferior part of L2 vertebral body being resorbed due to the unstable nature. Whenever the patient was standing and bending, the entire vertebral body used to collapse, and then it used to open up in the MRI in lying down supine position. It's already opened up with a large fluid cleft in the L2-3 disc space. So this is the case, this is the presentation that he came to us. Of course, we counseled him. We considered the option. It was very unstable. He was not even able to stand or walk for 5 minutes, and we thought that he will require some kind of a surgical intervention and stabilization. It's an adjacent segment disease, and we have to extend the construct from posterior, and that was the first option that we considered, and I wish we would have convinced him, and we would have done that in the first instance. I will tell you why as we go along. So we thought that it required an extension to L1 with cage at L2, 3, and 3-4 as well, because the 3-4 also there was a vacuum and a mild retrolisthesis. But the patient had actually come to us because he didn't want another open surgery. He had a lot of issues in the previous surgery because of the wound dehiscence, and he required another surgery for wound closure. So he wanted something to be done without touching the wound that was there earlier, because he was very concerned that might lead to the same problems again. And that is when we considered whether we can do, because this was an option. This was way back in 2017, and this was an option where we were not completely aware of the limitations of a standalone lateral OLIF surgery, and we considered an option of a standalone L2-3. Put in a cage, put in screws from the side, and probably that might be enough to stabilize him. So that is what was offered, and he also agreed. We explained the limitations. We explained that yes, it probably requires a posterior construct, and we planned for an L2-3 OLIF with lateral screws, no extension of posterior implants. And these were the days when we still had only 2D navigation, and these were some of the intraoperative C-arm images that we took, and we put in screws from the lateral and connected it with a rod. We were able to achieve significant amount of this one. We even sent the disc material fluid for a biopsy culture. Everything came out negative, and so this is how the final construct looked like at the end of the surgery. We were pretty happy with it. The cage was slightly posterior. It was avoiding the anterior resolved portion of the vertebral body. Patient also improved post-operatively. He started ambulating independently. He resumed his morning walks, and he was quite happy with the outcome. And again, unfortunately, 5 months again. 5 months later, he came back to us with recurrence of low back pain. Again, it was progressive in nature. He had the same radiating pain in the anterior thigh. Now it was going up to the knee as well. He was again unable to stand or walk for more than 5 minutes, and he started developing a stooped posture as he stood. And that is when we were in for a surprise. And this is how the X-ray looked at that stage. Again, we got a dynamic X-ray. This was nearly 5 months later. So as you can see, even though the cage is sitting well, it is not fused. Definitely there is a huge radiolucency. Again, this is another lesson that we learned. These were the cases, these were the days in 2018 when we were still using synthetic bone substitutes in olive. Nowadays, we have migrated again to an allogenic, cadaveric allogenic allografts, cadaveric allografts, which we get from our bone bank in Ramaya Hospital. So this is what it looked like. Now there are two things. As we can see, there is a significant retrolisthesis which has worsened as compared to the last time at L3-4, the previous construct, which we had not done anything in the previous surgery. And number two, obviously the L2-3 as well was not completely healing. It is not completely stable and fused. And the 2 screws that we have put from lateral is not sufficient to maintain the biomechanical stability required at that level. And that is also collapsing anteriorly when the patient is bending. And also there is a upper end plate fracture of L3, which is, which probably because of multiple screws in that vertebral body and because of the tension that was there due to the graft, due to the cage, and multiple reasons could be that. So again, now at this stage we were not sure. He was still, very symptomatic, and it had started only since 2 months. So he had already tried conservative treatment. He contacted us a few months back. We tried conservative treatment. We did physiotherapy. He, as a physician, he self-administered a course of steroids thinking that probably it might help him. We gave all kinds of neuropathic painkillers, but unfortunately there was no improvement. And he started to develop progressive pain, and his mobility further started reducing. So then we started discussing again, should we go back and should we do it again the same way, like open the posterior construct, open it, everything. But vehemently, patient told that, no, I don't want the old wound to be opened, and if you can do it in MIS in any way, it has to be done in MIS, so I don't want the old wound to be opened. And he was a very, very, very commanding senior, doctor, so that was there. So now we reviewed the previous implant. Unfortunately, we thought that we found out that the extender towers can be attached to the previous existing implants, and this is what we planned. So we planned again an MIS procedure. We opened from laterally. We attached to the old screw heads. We removed the innies. We removed the rod. We attached the extender towers to the old screws that were already there through an MIS technique. And then we put fresh screws at D12, L1, L2, and S1, because this was a long construct. He had some small osteophyte kind of ankylosing features at the upper level at the thoracolumbar junction as well. So we decided to extend all the way till D12. L3-4 was also unstable, so we decided to do again an L3-4 facetectomy from the back, because last time it was not done, laminectomy or decompression. So the L3-4 facetectomy with cage insertion and everything was done MIS, and this is what we ultimately got. So we were able to fuse. I know this ended up in a very, very grotesque way than what it was earlier. Patient had actually presented to another doctor with just an L4-5 canal stenosis and just a claudication symptoms, and unfortunately, a year later, he ended up with a multi-level fusion. So this is one of the cases that we always see that something that shouldn't have ended up like this. So there are several lessons learned. Of course, this was the case, or I have a couple of cases like this where we understood that a standalone OLIF is not suitable for an unstable segment. And we always have to have an anterior load-bearing cage at unstable levels. And this case, this is the place where we, I was referring to the L3-4 level, which continued to be unstable even after multi-level fixation. Of course, from these cases, we have done a few more cases, a good number of cases where we have reattached the extender towers to a previous existing implant, and we were able to revise our construct or extend the constructs in an MIS way. Thank you.